Assalamualaikum students, welcome to my class. Today I have very interesting topic for you, that is Olecranon fracture. Though it is not important for your exams, but the way it is managed is very interesting. And second thing is, it is one of the common fracture you get in your clinical practice. So before starting my videos, I would like you to subscribe to my channel, share and like it. These are prepared for undergraduates in a precise and exam-oriented manner. And only one topic is covered in each video. So we'll move on to the topic today. So today we have one clinical case. It is a 30-year-old male patient who had history of fall on the outstretched hand. Then after that, he had some forces transmitted over the elbow and he developed pain and swelling the elbow with a restricted elbow movement. So patient has fall on the outstretched hand and patient had swelling of the elbow joint. So this is how the patient with olecranon fracture present to you. So before knowing the fracture per se, we need to recall our anatomy, how the olecranon is. So olecranon is the proximal aspect of the ulna. Here you see it is a olecranon process. It is the proximal aspect of the ulna, which is having the groove that is olecranon here, fossa here. So which give stability to the elbow joint and do the flexion and extension movement. And there is one important muscle, which is triceps muscle inserted around the tip of the olecranon, which give extension movement to the elbow joint. So the one more thing I just want to add here is traction apophysis. What is the traction apophysis? In the children, what happens is when there is a growth at the epiphysis due at the attachment of the muscles, due to the continuous pull of the muscles, this epiphysis will become more prominent. So this prominent epiphysis is otherwise called as apophysis. So olecranon tip is a apophysis that is happening after the pull of the triceps muscles in the, on the epiphysis. So the mechanism of injury, anyhow, you know. So how will you classify the olecranon fracture? We classify olecranon fracture into three types. One is avulsion fracture. We have avulsion fracture. The others is transverse fracture, and the third is comminuted fracture. Each type of fracture happens depending on the mechanism of injury. They have different mechanism of injury. So avulsion fracture happens due to the sudden contraction of the triceps muscles. As I told you, this is the triceps muscle inserted over the tip of the olecranon. When there is a sudden contraction, it pulls the triceps attachment along with it. So there will be a break and avulsion of the fragment. This is how it presents on the X-ray. So there is a small avulsed fragment with the attached triceps muscle to it, which happens due to the sudden contraction of the triceps muscles. The other is the transverse fracture. Transverse fracture happens as in our clinical case I described in the beginning. There is an indirect force transmitted to the elbow due to the fall on the outstretched hand. So there is a transverse fracture or the fracture which have minimal comminution. So this is the example of the transverse fracture. And the third one is a comminuted fracture. It happens following the direct injury to the olecranon due to the fall on the elbow joint. So the forces are transmitting over the tip of the olecranon here. So it's the fracture is comminuted and the olecranon is shattered into the pieces. So if you see here, this is the direct injury to the olecranon with multiple pieces. So this is how the comminuted fracture, and sometimes there is a dislocation of the elbow joint also. So what is the presentation? Presentation, there will be a history of injury to the elbow. As I told, there is sudden contraction injury, or sometimes they have the indirect transmitted forces due to the indirect forces due to fall on straight hand or the direct elbow injury. So depending on the type of injury, they'll have the fracture. So pain and swelling at the elbow joint, and it's the swelling will be more on the posterior aspect. And as the triceps has attachment of the elbow extensor, that is triceps, tip of the olecranon. So if there is a deficit, then patient will have extension deficit. And if the fracture is displaced, then patient will have step. So if you see here, this is the elbow joint. So here patient will have step like this over the elbow. So if there is a displaced fracture. So how will you diagnose? We do X-ray lateral view. It will show you the fracture pattern. It will show you the dislocation. It also show you the comminution. If you see here, there is no comminution. It's a simple fracture. Here, there is no comminution, but the fracture has displaced due to the contraction of the triceps muscles. And there is a step on clinical examination here. And the third one is the multiple fragment here comminuted fracture. So this is how the X-ray picture is. Here you have the avulsion fracture. Here you have the transverse fracture or simple fracture. Here you have a 1, 2, 3, 4 fragments. So if you suspect some injury to the distal end of the olecranon or fracture pattern is very not obvious on X-ray due to some reason, then you need to do CT scan before you plan surgery. So what is the treatment? Treatment depend on the type of the fracture, depending on displacement and depending on the number of fragments. If the fracture is undisplaced, we prefer immobilization, applying above elbow cast in 30 to 45 degree of flexion. We should not increase the flexion because if you increase the flexion, the triceps will try to move the fracture away. So if you see here, this is the elbow. So here is your olecranon. And here the triceps attaching to it. So this is your humerus. So if you try to flex it more than 90 degree or 90 degree, what happens is this fragment will go like this. So the chances of displacement is high. So to try to maintain it aligned, you need to go do only 30 degree to 45 degree of flexion. And we need to monitor every week or 10 days to check any displacement happening after the fracture. Then if the patient is having displaced fracture, which is two fragment, only one or two fragment, very simple type of fracture, if you see here. So this is two fragment fracture. So what we can do is we can put the K-vads and would put the SSY. This is called as tension band fixation. I'll be telling more about this in the last slide. If the patient is having comminuted fracture, like here, if you have the multiple fracture fragments like this, then the tension band principle won't work because it need stable bone. So here you can put the plate after aligning the fragment fractures, we can do the plate fixation. So depending on the displacement, we can manage conservatively or if there is no displacement. If there is displacement, if the single two fragment fracture are very undisplaced and stable fracture, tension band wire. If it is a displaced fracture, then we need to go for plate fixation. What are the complications? Hardware-related complication. Why hardware-related complication? Because olecranon is subcutaneous bone. So generally, hardware irritate it frequently. So a patient will have pain and bursts of formation. So post after time, the olecranon implants need to be removed. So the patient may develop elbow stiffness. The patient may have neurological deficits because ulnar nerve and radial nerve is very close. Neurostatic ossificans as a routine complication after the elbow fracture. Arthritis of the elbow develops if there is no proper reduction or second thing is if one of the small fragment is remain inside the elbow joint, it will go on irritate the cartilage and patient may have arthritis. This is all about the ulnar fracture or olecranon fracture. Now I am telling you more about the tension band principle. If you imagine a tree which is moving inside the due to the wind, so this is the direction of the wind. So this side there is the compressive forces happening. This side there are the tension forces happening. So if it has to break, it will start breaking from here, and this break will continue, and patient will this tree will have complete fall like this. So the same way, this is depicted for some pipe or the stick. So what happens is in the olecranon, the same thing happens. This is a compression side of the olecranon tension side. So what we can do is over the tension side, you can put a K-bar like this and put a wire which is encasing the fracture. So whenever the fracture try to move away, this wire won't allow it. So it pushes this fragment again inside. So the tension forces due to the tension band are converting into the compressive forces. So compression forces are what we required for the fracture to unite. Fracture to unite, we need compressive forces. So this principle, what we use, it is called as tension band principle. And the wire is used called tension band wiring. So if the tension forces, when applied tension band, they are getting converted into the compressive forces. So we have compressive forces on the tension side, we have compressive forces on the compression side. So combined compression over the fracture will result in union. So this is all about the class today. So please like, subscribe to my channel and share it. Okay. Thank you.